The pair data model explained how health insurance data really works behind the scenes.
Hello and welcome. In today's video, we are going to break down the ideal data model for the payer industry, which means the data foundation used by health insurance companies to manage members, plans, providers, claims, authorizations, payments, care programs, compliance, and analytics. A payer data model is not just a technical database design. It is the operating map of a health insurance business. When it is designed well, it helps the organization understand who is covered, what benefits they have, which providers they can use, what services were delivered, what should be paid, what risks exist, and how the business can serve members more effectively. Let us start with the big picture. A payer organization manages relationships between people, products, providers, money, care, and regulations. The member is usually at the center of the model, but the member does not stand alone. A person may belong to a household, may be enrolled through an employer group, may have different coverage periods, may change plans over time, may receive care from many providers, and may generate claims, authorizations, appeals, grievances, and customer service interactions. Because of this, the payer data model must be time aware, relationship aware, and flexible enough to support both operational processing and enterprise analytics. The first major domain is the member and identity domain. This domain stores information about covered individuals, such as name, date of birth, gender, language preference, contact information, address history, household relationship, subscriber relationship, and member identifiers. A strong model separates the person from the insurance enrollment. This is important because the same person can move between plans, change employers, gain or lose dependents, or have different types of coverage over time. The member table should connect to member address, member contact, household member, external identifiers, consent records, claims, authorizations, and care management cases. The second major domain is sponsor, employer, and group data. In commercial insurance, coverage is often purchased by an employer or organization. In government programs, the sponsor may be a state agency, federal program, or exchange. The sponsor table represents the organization responsible for offering or funding coverage. Below that, the group table represents the insurance group, such as an employer group or policy group. A group may have divisions, employee classes, locations, or subgroups. These tables are important because eligibility rules, premium billing, plan offerings, reporting, and commissions often depend on group structure. The next domain is product, plan, and benefit design. A product represents the broad insurance offering, such as commercial medical, Medicare Advantage, Medicaid managed care, dental, vision, pharmacy, or exchange coverage. A plan represents a specific sellable option under that product. The plan connects to benefit packages, networks, premium rates, groups, and enrollment records. The benefit package defines what services are covered, and the benefit rule table defines details such as copay, coinsurance, deductible rules, out-of-pocket treatment, prior authorization requirements, service limits, and network tier behavior. This separation matters because products, plans, benefits, and networks often change independently. Network data is another critical part of the payer model. A network defines which providers are available to members under a plan and under what conditions. The network table connects to provider network participation records. The provider domain should include individual practitioners, facilities, pharmacies, labs, behavioral health providers, and other service organizations. Provider records should include NPI, tax ID, specialty, license information, organization name, location, status, and contract relationships. A provider can practice at multiple locations, belong to multiple networks, and have different contract terms across products or markets. Provider contracts and rates deserve their own structure. A provider contract defines the commercial or operational agreement between the payer and provider. It may be fee-for-service, capitation, bundle payment, value-based care, shared savings, or another payment model. Contract rate tables store payment rules by service code, procedure code, revenue code, diagnosis-related group, drug code, or other pricing method. This part of the model is sensitive because it directly affects claim pricing, provider reimbursement, medical cost management, and financial forecasting. Enrollment and eligibility are the bridge between members, groups, plans, and coverage. The enrollment table records when a person joins a plan, which group they belong to, who the subscriber is, where the enrollment came from, and whether it is active, pending, or terminated. Coverage tables define the actual coverage type, such as medical, pharmacy, dental, or vision. Eligibility period tables preserve the history of when a member was eligible for benefits. This is one of the most important areas to model carefully because a claim can only be paid correctly if the payer knows whether the member was eligible on the date of service. Claims are usually the largest and most used data domain in a payer organization. The claim header table stores the overall claim, including claim number, member, plan, provider, claim type, status, receive date, service dates, billed amount, allowed amount, paid amount, member responsibility, and payment date. The claim line table stores each service line, including procedure code, revenue code, modifiers, units, place of service, billed amount, allowed amount, deductible, copay, coinsurance, denial amount, and paid amount. This separation allows the payer to understand both the overall claim and each service that contributed to payment. Claims also need diagnosis, procedure, adjustment, denial, and payment detail tables. Diagnosis tables store ICD codes and sequence. Procedure tables store CPT, HCPS, ICD procedure, or revenue-related codes. Adjustment tables explain contractual adjustments, corrections, recoveries, or denial adjustments. Denial tables explain why a claim or line was not paid. Payment tables connect the claim to remittance, EFT, check, or other payment methods. Together, these tables support adjudication, provider payment, member explanation of benefits, financial reporting, audit, and fraud detection. Pharmacy data can be modeled as a specialized claim domain. A pharmacy claim includes the member, pharmacy, prescriber, drug code, fill date, quantity, days supply, refill number, ingredient cost, dispensing fee, patient pay, and plan paid amount. A drug reference table stores NDC code, brand name, generic name, dosage form, strength, manufacturer, therapeutic class, and drug category. A formulary table connects plans to cover drugs, tiers, prior authorization rules, step therapy, quantity limits, and specialty drug indicators. This domain is essential for medication adherence, cost management, safety programs, and pharmacy benefit analytics. Authorization and utilization management data helps payers manage medical necessity and appropriate use of care. The authorization table stores requests for inpatient stays, outpatient procedures, referrals, pharmacy approvals, or specialty services. It includes member requesting provider, servicing provider, requested service, diagnosis, request date, decision date, status, approved units, denied units, and authorization period. Authorization data connects to claims because a claim may require valid approval before payment. A medical necessity review table can store reviewer decisions, criteria source, decision history, and review outcomes. Care management and population health data add a clinical and engagement layer to the model. A care case table tracks members enrolled in programs such as complex care, chronic condition support, maternity management, behavioral health support, or transition of care programs. A care plan table tracks goals and actions. Intervention tables record outreach, education, medication review, appointment support, or follow-up activities. Risk score tables store calculated risk measures such as clinical risk, readmission risk, or cost risk. This domain helps payers move from paying claims to improving outcomes. Billing and premium data are essential for the financial side of the payer business. A billing account may belong to a group, employer, individual, or sponsor. Invoice tables store billing period, invoice date, due date, premium amount, adjustment amount, total due, and status. Invoice line tables connect charges to members, coverage, taxes, fees, or adjustments. Premium rate tables store rating area, age band, coverage level, plan, group, and effective dates. Payment receipt tables record money received from groups, individuals, or sponsors. This domain supports revenue, reconciliation, delinquency management, and financial reporting. Brokers, sales, and commissions may also be part of the enterprise payer model. Broker tables store broker or agency information, license details, tax ID, status, and appointment history. Broker assignment tables connect brokers to groups or members. Commission tables calculate and track commission payments based on premium, enrollment, product rules, and contract terms. While this domain may not appear in every payer system, it is important for commercial, individual, and exchange-focused business lines. Appeals, grievances, and customer service data help the payer manage member and provider experience. An appeal may relate to a claim denial, authorization denial, eligibility issue, or benefit decision. A grievance may relate to access to care, quality, billing, service experience, or provider concerns. Customer interaction tables store calls, emails, portal messages, chats, letters, reason codes, summaries, service requests, resolution status, and agent details. These tables help the payer measure service quality, comply with response timelines, and identify recurring pain points. Compliance, consent, privacy, and audit data should not be treated as an afterthought. Payer data contains sensitive health, financial, and identity information. Consent tables should record whether a member has granted or revoked permission for data sharing, marketing, care management, or interoperability use cases. Audit tables should capture who accessed which data, when they accessed it, what action they performed, and the purpose of use. Role and user tables should support access control. This design supports privacy, security, regulatory compliance, and internal accountability. Interoperability is now a major requirement for modern payer architecture. The model should support external identifiers and data exchange events across EDI transactions, APIs, portals, FHIR resources, clearinghouses, state agencies, provider systems, and employer systems. Common payer transactions include enrollment, claims, remittance, eligibility inquiry, eligibility response, prior authorization, and payment-related exchanges. A good model tracks source system identifiers, transaction status, errors, timestamps, and exchange type. This improves reconciliation and makes the payer architecture more transparent. For analytics, the payer data model should be extended into dimensional structures. Common fact tables include claim line facts, claim header facts, member month facts, premium facts, authorization facts, pharmacy claim facts, care management facts, provider performance facts, and customer interaction facts. Common dimensions include member, provider, plan, product group, diagnosis, procedure, drug, geography, network, date, and line of business. This allows leaders and analysts to answer questions about medical cost trends, utilization, quality, risk, revenue, provider performance, member retention, and operational efficiency. The most important design principle is that payer data changes over time. Members change plans, providers change networks, benefits change annually, groups renew contracts, premium rates change. Authorizations expire, claims are adjusted, consent can be revoked. Because of this, effective start dates, effective end dates, versioning, source system tracking, and auditability are essential. An ideal payer data model is not just a collection of tables. It is a living structure that connects coverage, care, payment, compliance, and business intelligence. When designed well, it helps a payer operate more accurately, serve members better, control costs responsibly, and build the foundation for digital health innovation. Thank you for watching.